Jennifer Bell is the bioethicist for Princess Margaret Cancer Center and research scientist with the Department of Supportive Care. She's an assistant professor in the Department of Psychiatry and member of the Joint Center for Bioethics at U of T. And Phyllis has joined UHN in 2005 and works at the corporate patient education specialist with the Patient and Family Education Program.
What we're hoping to do is start maybe from a higher level and just think about what some of the bioethical principles are in relation to informed consent, in particular one, which would be patient autonomy. We'll then review very practically what's required in the actual informed consent form, what kind of components need to go into it. And then Phyllis will talk about appreciating the importance of using plain language for preparing the informed consent document. And then we have some exercises that we can use to guide you through some practicing of using plain language to enhance our abilities to write good informed consent forms. And we also have some resources for you at the end. And these slides will be available, so you'll be able to get the resources afterwards, so don't worry about scribbling down. So why don't we just start at a very fundamental level here. When we talk about research, we're talking about something that's really critical to doing in order to essentially improve patient care. Obviously, we want to be able to advance our scientific knowledge in order to make a very real clinical impact in our institution. There are many types of research studies, as we know. We have basic questionnaire studies. We have some randomized controlled trials. They may be blinded or not. They may be multi-center or not. We have pharmaceutical trials, we have pharmaceutical drug trials, we have surgical trials, we have device trials, we have a lot of different types of trials and phases of trials going on here. And participants in many of these trials, in fact, essentially in all of them usually that I've listed here, participants are often a necessary component of the trials. I'm actually going to a research ethics board meeting. I'm missing it right now, so thank you. But I'm heading to Princess Margaret's research ethics board meeting directly after this. And we see all of the protocols that involve human participants, and we have many, 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 many protocols that we review. So the question is, at least a fundamental question is, well, we have to do research. We need to involve participants. How do we involve participants ethically in the research process? So just as a guiding question. Bioethics has been concerned about this question for a very long time, ever since World War II, when there were the atrocities that occurred to the Nazi concentration camp survivors. We have been concerned about participants' rights and our responsibilities as researchers towards them within the context of research. And so a primary governing ethical principle for conducting research is respect for human subject autonomy. And this came out of the World War II concentration camps, and there's been other examples throughout history, recent history even, that have really stated how important this principle is. And really, what does this mean in the context of research? It means helping people make decisions that are aligned with their own values and preferences and interests. And doing that usually occurs through the process of informed consent. So informed consent, we can see it as a way to actually empower people to make decisions that affect their lives and interests, and to also show them respect by providing them with the information to make their own decisions about whether or not they want to participate in that research process. Fundamental elements of informed consent include capacity, so somebody has to be capable in order to provide consent or refusal to research. There entails an obligation on the researcher's perspective of, or even in the treatment clinical setting for those of you who are doing the clinical consents, providers need to disclose the information to participants so that they can make an informed judgment and decide whether it is well within their values and preferences. And they also have to ensure that the participant understands the information that's been imparted to them. So there's a further obligation there. A participant has to make a decision that is voluntary, so they cannot be coerced, they cannot experience any undue pressure. And in the end, they have to make a decision. They have to either consent or refuse to participate or not in the research. So bioethics has an ethical principle, and informed consent is the practical application of it. Informed consent is also included in regulations and guidelines governing research ethics internationally. Here in Canada, we have the Tri-Council Policy Statement, which governs research ethics, human subjects research ethics. Internationally, we have the Declaration of Helsinki. In the United States, it bore in the Belmont Report. And there's various other regulations that say that we must ensure that there is a process of informed consent in order to respect patient autonomy. And it goes into detail about what that consent process needs to have in order to meet the requirements. When we think about consent to research in particular, there are some tweaks to the definition that I gave to you before. So informed consent or an informed consent form is a process where a subject voluntarily, again you hear that voluntarily, confirms willingness to participate in a trial after having been informed of all aspects of the trial that are relevant to the participant's decision to participate. That's pretty critical and actually a new phenomenon which has been tested in case law, actually in the treatment setting. It has to be information that subjects deem are relevant to their decision making, not what researchers think is important for them to hear, which is a slight nuance. And then it has to be documented. We have to have a written statement where we can show that a participant has actually agreed that they have understood and all their questions have been answered, although it's not sufficient for recognizing that that consent process has taken place. Who obtains consent? This is often a question that I think is less well understood, but it is the case that researchers and people who conduct the study obtain the consent. This is for a couple of reasons. It's to avoid undue pressure. So if a physician is doing their own trial and they have their patient population, we want to avoid a presumption that the physician, who's also the treating physician, wants to get the patient in their research and so could be coercive to that patient in participating. To avoid that scenario and also to recognize the information that a research coordinator has about the study, since this is what you're immersed in, we know that you're most well prepared to explain the trial to a potential participant. So it's researchers and people who conduct the study. Then the question is, how can you communicate effectively to people that aren't as knowledgeable? So of course, you know the study inside and out, you know what the protocol is. Maybe you've had a hand in developing the protocol, depending upon if it's an investigator-initiated study or if it's a pharmaceutical study. But you have the knowledge. So how do we communicate that to enhance potential participants' understanding of the trial? That's the question. So the process, so informed consent, actually obtaining informed consent, it's not just the signature on the form, it's actually the process that you have with the potential participant about what the study involves, what the risk benefits are, and essentially it's actually a meaningful exchange between the investigator and the potential participant. The subject signature provides documentation of agreement. It's only one part. Sometimes I think that there is this over-reliance on the actual signed document, when in actual fact, we know from clinical case scenarios in the legal system that a signed consent form means actually nothing. What really matters is that because a person can disagree and say, actually, I didn't understand what I was signing. And that is a basis for a court mediation between the two parties. So a signed consent form is not the end or the only part of the story. Really, consent forms are meant to present study information to participants to facilitate their decision-making and to ensure their autonomy. We often find, I think it's on the next slide, that the consent form many people take home and they'll refer back to. So if they do decide to participate, they might sign on the spot or sign at a later date, but then they use the consent form as a resource that they can then check back to and say, well, what were those risks again? So it's a living document for them. Again, not a one-time thing. It involves educating prospective participants, not merely disclosing information. Providing information is part of the process. Again, just to stress that a lot of this information may be new to people, or it may not. People may have experience with illness in the system, so maybe a little bit more familiar, which just means that we have to personalize it to the individual. But really, it's about not only, again, the disclosure, but also ensuring that people understand what perhaps they may be signing up for. So when we talk about essential elements of a study-informed consent, there are very particular categories that need to go into the consent. And these are presumptions about what patients or participants potential participants would want to know. So it has to involve a statement about the research and what its purpose is, the treatments, whether randomization will occur and what that randomization means, and we will talk about maybe how to plain language a lot of these elements, but what the procedures are, how many times do they have to come into the hospital, how many blood tests do they have to take, and so on. What are the risks? What are the potential benefits, inconveniences, alternative treatment options, and potential compensation if there is any. Oftentimes we will see compensation for parking and so on. There's also statements around voluntariness, whether or not there'll be access to medical records and so on. And you can have access to this list on your slides. What happens when we have poor consents? When we know that not only would it mean that we're not respecting somebody's autonomy by not providing them the information they need to make a decision that is aligned with their values, but also poor consent forms can lead to a failure to enroll. They just may not understand the study. They may have a misconception that's not rectified by the consent form, and they may otherwise have participated. They could have unexpected responsibilities, which may lead to poor compliance. So maybe they thought that they only had to come in for, once a week for 3 months, but in essence, actually, they have to come in for twice a week for 3 years. That could have huge ramifications on their ability to participate and then their ability to comply with the study protocol. It may lead to high dropout rates for many of those same reasons. Potential legal repercussions, they're not consenting to what they thought they were consenting to. And just generally, it can lead to unhappy relationships between participants and study staff when there's misconceptions. So all in all, not good scenarios. So solutions, of course, is to prepare good consent with some of the resources that we're going to give you today and at the end of the presentation. But use your colleagues as well, because a lot of this has to do with knowledge of the resources and some of the templates that are available, but also the ability to communicate very high-level information, very complex information when it involves sub-studies, separate consent forms, separate treatment arms. We have like 4 treatment arms. Some are randomized, some are not. So oftentimes handing these things to our colleagues can help with plain language and also making sure you're covering your basis in terms of the information that people need to know. The regulation guidelines can also help you. So just to summarize, for key points in writing a consent form is to think about your audience and who will be reading the consent form, and maybe just start from a fundamental assumption that they're not going to know some of the very difficult words that might be used, the medical language that might not be familiar to them. I mentioned this a little bit before, but there's a reasonable person standard that should be used. And this is just essentially, it's actually, again, derived from a clinical case scenario where it was determined that it's not what the researcher thinks you should know, it's what the patient wants to know or the potential participant wants to know in order to make a decision. So it's about disclosing enough information so that they have the information available to them if they want to know about risks and benefits. But if they really just want to know, what is the chance that this drug might actually have some benefit on me, then giving that information to the participant might be the most important piece of information that you can to them, and explaining to them the fact that it's a trial, the fact that maybe we know this already, so maybe it would lead us to this, the fact that it's a phase 3 trial maybe as opposed to a phase 1 trial. So again, it would be tailoring it to what they want to know. The person should clearly understand the risks and benefits and the voluntary nature of the study. And again, thinking about it as a process, even if somebody consents at the beginning and goes into the trial, things may change and there's an opportunity for them to learn more information about maybe there's another study that just came out that showed actually this drug is really harmful and it doesn't pass the test of favorable risk-benefit. So we're actually going to provide the participant with that information, which may change their desire to participate in the study. So we have a duty, as researchers and the investigators do as well, to ensure that participants get that information because, again, according to the reasonable person standard, it might be information they want to know that could change the fact if they want to participate in the study. Writing informed consent forms, there's resources for you available to do that, and you'll have these on your slides. And then looking at some particular challenges, Phyllis will talk to you about health literacy.
All right, so plain language. I think we've touched a little bit on why it's important. Now what it is a way to present information that's easy to read or hear, because of course you can use it when you talk as much as you can when you're writing, and easy to understand and easy to use. So important to realize that difficult texts do a number of things. They cause errors, so people can easily misunderstand when they're reading difficult information. They can also be very dissatisfied. So what we know from other studies on sort of satisfaction surveys that compare difficult documents to more plain language documents is that people complain. They call back. They don't know what's being asked of them, and so they will call back and complain about the kind of service that they've received. So that's something we see in other kinds of documents, legal documents, insurance documents. There's a whole lot of research that looks at that. And what we know for sure is that all patients, everyone who does what we just sort of started off this talk doing, is comparing the two versions, are much more satisfied with clear and unambiguous information. All right, so one thing that we hear quite a bit is, well, how do I know if I've written something that's perhaps a consent form, or so you're working with somebody to consent a research project? How do I know that that document is written in plain language, is adequate enough for the patient or the study participant? So there are ways that you can evaluate forms, and they're actually in your own. They're in the Microsoft suite, so you can click show readability statistics when you do a spelling and grammar check, and you will get this box that pops up and shows you the readability grade level. So that's that last one there. And in patient and family education, we do recommend that documents are written at around a grade 6 level. So this doesn't guarantee that all people will understand, but it certainly does broaden how many people will be able to understand your document. However, having said that, it's important to realize that it's just one way of evaluating whether a document is clear and unambiguous, easy for someone to understand. What would be other ways to test whether this is the case? Sure. Give the document to someone else. Yeah. The grade 6 reader might not have all the context, but if it's important for you to understand certain parts of the consent, then the other question is asking the question in a way that has them respond to you by not asking, for example, do you understand, but testing whether they've understood by asking certain questions around the consent form. So those are a few ways. And again, I'm going to mention just some of the tips, and knowing that there are so many more things that you can do to ensure that something is written in plain language. So the first is using common words, not jargon. Explaining medical terms that patients need to know. Why is this one important? Why wouldn't you just go in and not include them at all? I mean, they're going to raise the readability, the reading level of your document for sure. So why would you not take them out? Mm-hmm.
The way that they're going to understand and how that could affect their body, not just on the inside, but like what it could actually do to them.
Right. Absolutely. What else?
We talk about informed consent, so patients should know what they're signing. So you can't just omit all the medical terms, or else you won't properly
Mm-hmm.
But I like how you put need to know, so put like what's necessary,
Right.
like in a way that they understand.
Mm-hmm.
Yeah, so,
Mm-hmm.
so they understand it, but also they get what they should know.
And to remember that people can then learn those terms and take it with them when they're looking at information online, for example, or talking to their friends, their family about whatever that medical issue is. So there's important reasons to include it. We're not saying don't ever include medical terms, but certainly explain them in plain language. Okay, so using short words and sentences, I feel like when I read that opening paragraph, that one sentence versus the 5 that was in version 2, gives you a sense of why it's important to stop and have one idea per sentence. Okay. Now, just a quick comment about short words. While this is important, short words are not always uncomplicated. So, for example, is diet a way to lose weight, or is diet something that you need to, kinds of foods that you need to eat when you've been, for example, first diagnosed with diabetes? So it's really important to realize that words like diet or goal can also be very broad. Some very short words can be vague and may also require explanation, right? And then writing directly to your reader. So in the first version of that consent form that I read, the opening was, I, blank, hereby authorize, blank, to perform the proposed procedures, et cetera, et cetera. And so it sounds like, wow, I'm reading that consent form. But in fact, the second version starts with your doctor has proposed this treatment. So a much more personal way of making the person who's reading the document feel like they're actually involved in the process is by referring to them as you or we when necessary. And so that's why we would also recommend using the personal pronoun, something that people are often not used to doing when they've been doing so much academic writing. For example, you don't use the I and you don't use the we and the you. But we recommend that consent forms absolutely include that so people feel like they're involved. So that's a very important one. And then using the active voice. So rather than, this medication is to be taken at a particular time, take this medication and at whatever time. So that's probably not a great example of active voice. What's another good example of active voice versus passive voice? I don't know. Yep.
Well, you should take these drugs before bed. Instead of take these drugs before bed.
Yeah.
You should leave it to ambiguous.
The should does that as well. Yeah. It also is a bit, there's a condescending kind of tone there. There's also a tone created instead of just the very factual, educational type of instruction, which is take the medication at this time. Okay. And writing instructions in the order you want them carried out. So important for consent forms that have a whole number of dates and tests that need to be done at particular times. So what's a good way of doing that? You don't need to simply list them in one very long paragraph. It's perfectly fine to set them out in tables. When you are listing, especially if there are more than 3 points, list them with bullets. Use bulleted lists if you're offering more than 3. I mean, the bulleted lists are ideal between 3 and 7 points, not really more than that. Then you need to sort of break them up even more. And that's it for me.